I appreciate y'all RSVPing and actually following through with that. I think that's a awesome asset for us when we're watching our budget. Today, our wellness program is on kidney stones, and our speaker is Dr. Deanna. Dr. Deanna joined Arkansas Urology in 2004. He received his medical degree at the University of Guadalajara, and he earned his bachelor's degree in pharmacy from the University of Arizona in Tucson. He has a bachelor's degree in zoology from the University of California in Los Angeles. He was the chief resident of urology at the University of California Davis Medical Center and was certified in lithotripsy, I think I said that right, and shockwave lithotripsy. Before joining Arkansas Urology, he had a private practice in Paragould and was served as the chief of surgery for Department of Arkansas Methodist Medical Center. So Dr. Deanna is certified by the American Board of Urology. And I'll turn the presentation over to Dr. Deanna. Thank you.
Thank you very much. I want to thank Sandy Simmons and Baptist Health Medical Center for asking me to speak with you today on a urologic condition that I think is of import to many Arkansans. We're going to talk about urolithiasis, or stones in the urinary tract. Now, before we get started, let's talk a little bit about what urology is. It's a surgical field and also a medical field. We spend about half our time in the office and the other half in the operating room. So it's a well-balanced specialty. We deal with urinary tract conditions for both men and women. And we deal with conditions in the male genital tract. Although of late, of the last 10 years or so, we've been branching out to deal with genital areas of women. We're doing pelvic reconstructions and this sort of thing on women and taking care of their leakage that goes with it. Now, a urologist is kind of a friendly, funny, and happy surgeon. And why is that? Well, we have a very tightly defined field, so it's a discrete field, and we really are true experts. We know more and more about less and less until we know everything about nothing. But it makes it a little easier to have a handle on, and it's a very rapidly evolving specialty. We have a lot of new things coming up and dealing with prostate cancer, surgical techniques, reconstructive surgery, etc., that makes it very interesting to be a urologist. The other thing that's really important about our field, what we do works. We deal with patients who have conditions that we deal with them and they usually get better. As a result, we have a better surgical lifestyle. We don't have a lot of emergencies. We do have some. Our patients don't usually die. So that makes it a lot better to deal with when you're doing a lot of surgery. So most of the conditions are not life-threatening. And as a result, many of our general surgeons are quite jealous about what we do. And I don't blame them. Now, we do have a lot of subspecialties in urology, from laparoscopy. I'm sure you're all aware of robotic surgery. And we've been doing that for prostate removals and for kidney removals and for actually now for stone removals in the ureter. We also deal with stones in endourology, putting scopes in urethras, and we make a few extra holes and put scopes there too, into the kidneys and some other things, directly into the bladder. We deal with cancer of the prostate, testicles, penis, kidneys, bladder. I think we're running out of GU topography there. Also, we do a lot of reconstructive surgery, so we do have a component of plastic surgery. We do reconstructions of genitals, reconstructions of drainage tracts in the kidney, etc. So that adds another component to our complexity of what we do. We are also responsible for kidney transplants. So we do the kidney transplants, or many of us do. And we deal with male sexual dysfunction. But unfortunately, because of lack of interest in a gynecology field, we've been starting to branch out towards female sexual dysfunction. And there's actually a subspecialty, there's a specialty in medicine called sexual medicine. It's a relatively new field, and it basically focuses on both men and women, but the real focus or interest is in women's sexual dysfunction, which is very, very complex. That's why most people don't want to deal with it, but we're trying to start taking that on also. Also, we deal with male infertility, the male factor in infertility. And lastly, we also deal with children and their urologic problems. Now, how many here have kidney stones? Okay, how many know people who have kidney stones? That's why we're talking about kidney stones. Now, stones were first were seen as far back as 4800 BC in Egyptian mummies, and the prevalence through our society is about 2 to 3% of people have kidney stones on board. The lifetime risk factor for any man in this room is 20% to get a kidney stone. Once you get a kidney stone, you've got a 50% chance of getting another one in 10 years. Now, women are at a little less of a risk for stones than men. They're at about half of what men's risks are. Now, what causes kidney stones? We get a supersaturation of urine, which is dehydration. You either have chronic dehydration, you've been told, oh, I don't drink enough water. That's one of the major components. Other is you may drink plenty of water, except you went on a hiking trip and got extremely dehydrated for several hours, and that can cause stones to start. The nidus, the seed. Once you get the seed, it's a downhill battle unless you have inhibitors in your urine that prevent those seeds of crystals from aggregating, which is the next one, crystal aggregation. Now, some people have stones because of their anatomy. If you have obstruction where you don't have good flow of urine coming from your kidneys, blowing through your tract, urine sits there. I don't know if any of you ever done this, but if you ever had a cup of urine and you just kept it there and sat it there for several hours, it'll become cloudy. If you have nothing else to do, try it. Anyway, it becomes cloudy. That's the crystals starting to aggregate and fall down. It's usually amorphous phosphates. Okay? So we need to have flow of urine to kind of keep things moving. Now, one other thing that we have lack of flow, not only anatomical, like obstructions in areas of the drainage, or for example, up at the kidney, when you have a scar in the ureter, the tube that connects the kidney to the bladder, if it's scarred, dilates. A lot of times people who have a tendency for stones will form stones in their kidney. Pregnant women are notorious for getting stones because they have, for a variety of physiologic reasons, have stasis. Their urine doesn't flow as well. The ureters are not as contractile during pregnancy due to estrogen effects. Plus, they have a higher excretion of calcium in their urine, so they're a setup for kidney stones, which is one of our challenges, dealing with pregnant women with kidney stones. Also, people who have bacterial infections. Chronic bacterial infections can cause kidney stones. They're called struvite stones or infection stones, and those are very problematic. Also, a lot of people who have kidney stones may have an intrinsic defect in their kidneys where they're producing, where their kidneys cannot hold and keep the calcium and other things in the body. They let it leak out into the urine, so there's another risk for it. Now, the extrinsic factors for urolithiasis include geography. We're in a stone belt, guys, girls, so we're kind of set up for it. And we have a hot climate. A lot of the places people work are not air conditioned. A lot of people don't drink. They don't drink enough water, and they replace it with my favorite, which is job security for urologists, and that's soda. Soda is very good for us because it gives you lots of oxalates, which is a main component of kidney stones, has a lot of caffeine in it, which also causes kidney stones. So we like soda for job security. Diet, people have a purine, oxalate, and sodium. If they're too high in those contents, then that'll tend to be a contributing factor to stones. Also, occupation. If you're sitting down, don't get a lot of exercise, you tend to absorb calcium from your bones. That increases your calcium level. You control it with your parathyroid. So I said, my God, we got way too much calcium, and you've got to get it out so it goes in your urine. That's really a problem with patients who are like quadriplegics, paralyzed patients, paraplegics, They get stones because of their inability to be mobile, and really it's a terrible condition, and we call it stone cancer because it really ends up, they lose kidneys and go on dialysis. All kinds of bad things can happen. They get septic from their stones. They usually have infection stones, so they end up having a really bad complex of things with having a sedentary life. So stay active, and that'll help you. Intrinsic risk factors, genetics. You know, you just got to be careful when you pick your parents, you know, because there's a major component of heredity for kidney stones. And even though a lot of us can get away with sodas and dehydration and all of that and not get kidney stones, but some of us can't. So a lot of that is genetics, and it has to do with different things that are genetically imposed, like making inhibitors and other things. Usually it affects people in their 20s to 40s as the peak, although I take care of 2- and 3-year-olds with kidney stones, and I have 90-year-olds with kidney stones. So, also, as I said before, it's men 2 to 1 compared to women for frequency. Now, most people has kidney stones, so why doesn't everybody get it? Most people have crystals in their urine, but why don't most people get kidney stones? Well, we talked about the anatomic abnormalities, the modifiers of crystal formation, which are the inhibitors of stone formation. Okay? These are citrate or citric acid, magnesium, urinary protein, which is part of the genetics of it, is a nephrocalcin that prevents aggregation of crystals, and lastly, pyrophosphates, also found in your urine. Now, let me explain what you're looking at. This is a stent. This is the opening in a bladder. This is a stent. This is a tube that's come from the bladder, a lot of side holes, and it goes all the way up to the kidney, and it's draining. This stent was put in 3 months before this picture was taken. It was not put in for kidney stones. It was put in for something else, and I took a picture of it. Notice, nice and shiny, clean. Here's a stent. It's been in 2 weeks in a patient who has active metabolic stone disease. A lot of barnacles growing on there, a lot of incrustations. So that's the importance of urinary inhibitors. Okay, so some of them are genetic. We have them naturally or we don't. Others are diet-induced. So we'll talk about that. Now, stone composition, as you can see here, the majority of stones are calcium in the form of either calcium phosphate, calcium oxalate, or a combination of both. These are the diamonds. They're rock hard. Calcium oxalate monohydrate is the hardest stone we have. Very hard to break. Calcium oxalate and phosphate combination a little softer. Calcium phosphate is a softer stone. Struvite's an infection stone. Cystine is genetically, people have cystinuria. It's a genetic issue, and they have their own form of stone cancer. That's a very difficult condition to treat. Uric acid stones are 5 to 10% of patients. Those are the only stones you cannot see on a plain x-ray. But those are also stones that you can dissolve with medication. Cystine stones you can also dissolve under certain conditions. Now, these are just some of the conditions, diseases associated with a high calcium in your serum or in your urine. And if you don't know what they are, you probably don't have them. But the main one here, we see that with people with severe diffuse cancers will get kidney stones just from the breakdown of tissue. It forms a lot of different products that go in the urine and causes crystallization of stones, and this can be a problem. We know a lot of people are taking vitamin D. Probably you go to a doctor now, everyone gets a vitamin D level. It's a very good vitamin, antioxidant. It also increases calcium absorption, which is okay. It's okay as long as we take care of other business. But if you take too much of it, you get excess and you end up with hypercalciuria, and that could cause stones. Some other cancers you see here, leukemia, lymphoma, multiple myeloma, and sarcoidosis. Natural history of stones, about a quarter to a third of stones, when we find them causing symptoms, are in the kidney. But the vast majority are in the ureter. And that's the tube that connects the kidney to the bladder, and I'll show you a schematic on that later down the road. The majority of the ureteral stones are in the distal third of the ureter, which makes it, that'll affect how we treat those. stones affect either side about equal amount, and about 10 to 15% of patients who present with stones will have stones in both kidneys. These are the patients with active stone disease for sure. The good news is the majority of stones, almost 80% of stones, will pass on their own given enough time. But unfortunately, most of the stones that we operate on that probably could pass, patients don't have the time or the patience to go through the grief of waiting 3-4 weeks, missing work, etc., taking medication and try to pass them on their own. So we a lot of times will do it to take it out so they get them back to work. But the majority can potentially pass on their own. And when we talk to a patient, it's important to decide what we're going to do for them by their history. Have they had prior stones, and what are they made of? Are they the hard stones? Are they the ones you can't see? Are they soft stones? How big are they usually? Do they usually pass on their own, or do they require intervention? That kind of helps us. So I have a lady comes to mind. She'll get a 2-millimeter stone, very tiny, and she has yet to pass one. She gets multiple stones, and you have to take them out. She just does not pass stones. She's got a very narrow ureter. It's very hard for her to pass stones. So that's all more important for going for prevention. Now, for fluid and diet and fluid advice, of course, water, water, water. Dilution is the most important factor. When we talked about supersaturation of urine that causes stones, dilution. They did a study many years ago. They took people who were active stone formers. They were passing 6 or more stones a year. Big-time stone formers. They divided them into 2 groups. One group, they said, you're our controls, you keep doing what you're doing. The other group, they said, you do the exact same thing you've been doing except for one thing. We want you to drink 80 ounces of water a day. That's 5 16-ounce bottles of your bottled water a day. After 1 year, these stone formers who were drinking the water cut their stone frequency by 68%, just by water alone. So when I tell people about diet things to do, if they have to have that Mountain Dew in the morning or that Diet Coke or that Coca-Cola or whatever, I'll tell them, fine, you have that, but wash it down with a bottle of water. Dilution is a very important thing. We can make people change a little bit for a long period of time, but not extremely severely for very long. So that's a good way to go with it. We also want to restrict salt. If you eat more, we all take too much salt. That's why we have kidneys. It gets rid of that extra salt. But if your kidney gets overworked excreting that extra salt that you don't need, then it can't pay attention to the calcium in the blood that it's filtering, and the calcium kind of sneaks out. That's putting it kind of simplistically. But so one way to decrease the amount of calcium that you put in your urine is by cutting back on your salt. Very important. When we do studies, we find out if they're excreting extreme amount of salt, that's highly suggestive that they're getting too much calcium in their urine. Also, restrict oxalates, which are the big burden. Remember, most of those stones had oxalates in them. And oxalates are the hard stuff. We find those, and you'll have our diet list there. It'll show you what oxalates are. But generally speaking, all the good stuff. Chocolate, sodas, tea, anything with caffeine will increase oxalate excretion. Okay, those are the dark green vegetables in excessive amounts can also do that. Certain nuts like peanuts. So if it feels good or tastes good, it's bad for you. That's kind of a general rule we have in medicine as we get older, and that definitely goes with this. And avoid high intake of purine foods. Those are the kind of the rich foods, the foods that people talk about if they get gout. That's the same. That's purine diet. Okay. And we'd like those people to increase their intake of citrus, particularly lemonade or orange juice. It's high in citric acid, which is, as you recall, an inhibitor of stone formation. So we like to get the citric acid up high. So again, drink fluids, water, or try to avoid a lot of sodas and all that stuff. Cut back on your salt. Restrict your oxalate and avoid really rich foods. Again, you can do all of these things if you wash it down with a lot of water, okay? So you don't have to completely stop it. And we'd like you to drink a lot of citrus. Now, so we tell our patients for prevention, increase fluids, decrease those things, supplements, orange juice or lemonade, or we add magnesium, vitamin B6. there's a brochure here, and did you hand it out already? Okay, it's here. This is a brochure. We give this to our patients. It's a company that we use, and we don't deal. We just give them your phone number. We have a deal with them. We told them if we send them patients, they'll give our patients a discount. So you use a number on this, and you call a phone number, and they deliver. It has all those things in it that you need as inhibitors, and it tends to really help decrease stone frequency. We use it on almost all our stone patients. It's a good thing to be on. Okay. If you happen to go to a urologist who wants to stop you from getting kidney stones, he may do a metabolic stone evaluation. And this is probably the most important thing you can do if you have kidney stones. If you have recurrent kidney stones, the most important thing you can do is go to a urologist, get a workup to find out why, so things can be done to help minimize the frequency of stones. It includes, it's real simple, there's not a lot of violation of your body parts. It's just a 24-hour urine collection and then some blood work. And then looking at what you're excreting and what's good in your urine, what's bad in your urine, what do we need to do to kind of straighten that out. We check how much urine you're making, which is important. As a general rule, and you guys can try it at home, everyone should be urinating 2 quarts a day. I don't care what you drink in volume, you should be peeing 2 quarts a day. And if you're a man, 2,500. Okay? So if it's real hot out, you got to drink more than when it's cold out, just so your urine volume is 2 quarts or 2.5 quarts. Very important. If we do find that you have a high calcium excretion, of course, we'll cut down on your salt. We'll also increase your, decrease your calcium intake. That's the only time we would decrease calcium intake. If you have kidney stones and a normal excretion of calcium, and you don't have hypercalciuria, high calcium in your urine, I don't have any problem with you taking calcium. You need calcium because we don't want to deal with osteoporosis, osteopenia. I just want that calcium in your bloodstream and in your bones and not in your urine. And the way you do that is cutting back on your salt. Okay. Yes?
The urine, if it's dark, is that a bad sign?
Depends what it's dark from, but usually it means it's real concentrated. Yes, that's a bad sign. It's got to be a very pale yellow. See this thing, much lighter than this. Okay, much lighter than that. Now, your physician, your doctor may prescribe for you based on what your metabolic stone workup is. He may prescribe some prescription medication for you, which would include hydrochlorothiazide, which is a mild diuretic, but it decreases calcium excretion. Uracid K and allopurinol, both which have their own little thing they do in the urine to prevent stones. Now, what kind of, I bet most patients people who've had kidney stones don't forget what it felt like. Pain. When we were in medical school, going through my surgical training, would go into the emergency room, and you can pick a stone patient out across the room. They'll be laying on the gurney, bouncing all over the place. They just cannot get comfortable. That's a kidney stone. Women who have had children and who have had kidney stones say kidney stones are much more painful than childbirth. So men, you can feel your badge of honor when you have a kidney stone. So you get abrupt onset of pain. It could come any time. You can't get comfortable. Depending on where it is, will dictate what kind of symptoms you have. It may be in your flank, which is up here, and over here. If it's up in your kidney, if it's in your ureter, it could be up there, but it could also be down here. And it could, as it goes down, it'll radiate down towards either your testicle or labia, depending on what sex you are, and maybe even to your medial thigh. Okay. And as the stone gets closer to your bladder, where the ureter inserts in the bladder, you saw that little tube that was coming out, the ureter is inserting in the bladder. As it gets closer to the bladder wall, it irritates the bladder wall, and you feel like you have to pee all the time. You got a lot of urgency and frequency, and you feel like you're not emptying your bladder. That's good. That means it's getting close. It's almost passing. Once it gets in the bladder, generally speaking, you should be able to pee it out. Should not be a problem, most of the time. Sometimes they get stuck in the bladder, people don't know it, and we see them back 2 months later and they got a bladder stone the size of a peach or something, or a small lemon. This kind of shows you the topography here. This is left facing forward. There's your right, that's a left upper quadrant here. And if there's a stone goes down, the pain could be down here and it radiates all the way down to the scrotum or labia. On the back side, there's your flank. Notice it's at the bottom of the rib. That's the last rib, your 12th rib over there. Okay, so what do? We look at you, you come in, you got the pain, so you get your urine checked. We'll look for red cells. 25% of patients who have kidney stones don't even have any blood in their urine, microscopically or not, so that's not as helpful. There probably will be some white cells from the stone irritating the ureter, but if we see bacteria, then that might be a problem. If we see bacteria, then definitely we put on antibiotics. If you have a fever, that's one of our semi-emergencies, and then you get admitted to the hospital. But we'll go over that in a second. Here's some pictures of the various crystals. I'm not going to go into them, but this is the kind of crystals of the various stones you have. Just so you know, if that is calcium oxalate, that's the killer right there. We do some investigations. Plain film of the abdomen, we call it a KUB. For years it's been called that: kidney, ureter, bladder. Just plain x-ray from here to here. We'll show some of those. Intravenous pyelogram, which used to be the gold standard when I first was through my training a few years ago. And we'll talk about that, or ultrasound of your kidneys, and CT scans, or computed tomography, which is pretty much what we're doing now most all the time. Here's the anatomy. Kidney, got the calyces up here where the kidney is, but just think of it as a filter. Filters the blood, and by the time it gets done, it has selectively filtered things out and made it urine. It drains into a kind of sewer pipes here, and then it comes down. This is the renal pelvis. Here is the uretopelvic junction. As it goes down, it crosses the iliac vessels, that are the vessels that break off your main ones, go down to your legs and your pelvis, and down to the uretovesical junction as it enters the bladder. That's where that stent was, coming right through there. Now, these areas are labeled because this is where stones get stuck. At the uretopelvic junction, the next titus, which is actually, the tightest part is down here, right at the opening. That's the tightest part of the ureter. The next tightest is a crossing of the iliac vessels. And the least tight, but still tight, is at the uretopelvic junction, where the renal pelvis sort of funnels down to start the ureter. Okay. Now, this is a KUB, plain film of the bladder, kidneys, and all that. See all this little stuff here? That's all kidney stones. Oh, you're going to see some, we'll see some others as we go through. This is an ultrasound. It's not a baby. It's a kidney. There's its shape. There's the calcium right there. And you notice that it has posterior shadowing. The ultrasound waves start up here. They come down. The kidney stones do not let it pass, and you have shadowing. So that shows you they're kidney stones. You don't see dilation in this kidney. You just see them kind of parked up out in the periphery. An intravenous pyelogram. You get a scout film, which is the KUB. You get your intravenous contrast is given. You then do your serial x-rays. So you get a plain film, then you inject contrast. You'll start seeing a nephrogram, which will show this part of the kidney here. Just that's the nephrogram. And then you wait a little longer. You get a pyelogram phase where you start seeing contrast in the renal pelvis, in that area. And then you delay it, and then you start seeing the ureters coming down like this. Kind of a lazy S, both sides. And then the bladder. Unfortunately, when we look at x-rays, they're not quite nicely labeled like that. This right here, this little shadow here, is your psoas muscle. Important structure surgically and otherwise. And to put it in context, if you were a cow, that would be your filet mignon. Okay? Here's a plain film on an IVP. There's a stone. Now this is, there's actually a negative filling defect here, and I'm not sure what that's all about, but actually the stone is right here. There may be another one here we can't see. It's hard to say. This is a CAT scan. Now, we look at it a little differently now. Originally, when CAT scans came out, we used to get this 3 or 4 big old x-ray things like this, and you'd have to follow the patient down, the study down. Let's look at it this way. Make believe you're looking at someone laying on a table, and you're looking at the sole of their feet, and you're looking at them, and then it's like a big bologna, and you're making a slice, and you're looking at the wet end, okay? You're looking, and you're taking a slice. Transverse slices serially. You're starting off high, So that's the liver, and that's a distended stomach, actually. It's kind of an interesting. There are the ribs, okay? We're coming down 5 millimeters or a centimeter. You start seeing more and more and more. Now, we're starting to see the top of the right kidney. Remember, this is right side, this is left. There's skin. There's your summer coat, the winter coat, I should say. And if you ever want to get a CT of yourself, you'll say, God, I got to go on a diet. The x-rays don't lie. Here's your spine. And anyway, we keep going down. There's the top of the right kidney, the left kidney. There we go. We're working our way down all the way. And you can see as we go down all the way down to towards the pelvis. But that's basically what a CT scan is. Now, here's one picture. Non-contrast. Remember, we don't want to usually give contrast for patients that will obscure stones. CT scan, no stone is invisible on a CT scan, generally, unless it's a medication stone. But here is, you can see this kidney stone in the left kidney, just minding its own business. Here is a hydronephrosis or dilation of the collecting system, the renal pelvis. See how dilated it is? You can't even see it on this side. This little mass here is just a benign renal cyst. You don't have to worry about that. So we take it down a little further, and there it is in the ureter. There's your filet mignon right there, psoas muscle, and there's the stone. Okay, so it tells us a lot. Then we can measure this off of the computer, tells how big it is, we know exactly where it is, and then we can talk about, well, what are we going to do with that sucker? So then we start talking about treatment options. So, conservative options, which is the majority of stones. Remember, 80% of stones will pass on their own. So what do we do? The simple stuff. Hydration, pain medication. If you have nausea, we give you something for that. And we use now, over the last few years, we've been using what we call medical expulsive therapy. We give them something like tamsulosin. You may know that drug as Flomax. You know, the Flomax boys, the commercials for that. It dilates the prostatic urethra so that you could pee better, for men could urinate better. But we also found out it dilates the ureter. So the ureter kind of opens up and more compliant and allows that stone to pass. And it actually works much better than not using it. So if you go to the emergency room and you say, I got a kidney stone, they'll give you some IVs. They'll send you home if they can on oral pain medicine, something for nausea, and they'll probably put you on Flomax or tamsulosin and give you a strainer and tell you, see your urologist or your doctor in a few days. Stones, a general rule on a general patient, and this can change, 5 millimeter stone or less, 80% chance of passage on their own. So again, the majority of stones will pass on their own. Now, why would we bring patients into the hospital? Solitary kidney with a stone, not good. Blocked kidney, they go into renal failure. So that, or if they're in renal failure from dehydration, we'll bring them in for rehydration. If their pain cannot be controlled with oral pain medication, we can't get them home, well, we'll bring them in the hospital. If they have intractable nausea or vomiting, well, obviously bring them in the hospital and get that controlled with IV fluids. You can't get someone hydrated if they're vomiting. And one of our emergencies is pyelonephritis. They come in, they have infected urine, they have a temperature of 102, their blood pressure is down, and they've got an obstructing stone. That's an emergency. That's urosepsis. You get in, and we have to treat that urgently. Fluids, antibiotics. We'll usually put one of those funny-looking stents up, alleviate the blockage. A blocked kidney with infection acts very similar to a big abscess. So they get very sick. So we tried the conservative stuff. We admitted you to the hospital, you got your IVs, or we sent you home. Now let's say we look at that and we have to decide, well, this stone isn't going to pass, or you just don't want to wait for it to pass, so how are we going to treat it? We have several different ways to do it. One is with shockwave lithotripsy, which is one you've probably heard a lot about. We'll go into a little bit of that here, where we could break the stone up. The other one is using a ureteroscope, going in the bladder, up the ureter, and doing something with the stone, either breaking it up with laser or something else, or just pulling it out, or both. Or percutaneous nephrolithotripsy. It's actually PCNL, but the P is PNL on this slide. And that's where we stick a tube through the back, right into the kidney, and we go, and then we can either break the stone up and pull it out, or just laser it, or just pull the stone out without breaking it up. Or open surgery. Now, we used to do it when I was in my training a few years ago. That's all we did. I mean, everyone got their stone taken out, and then we, as got into practice, we started evolving into ureteroscopy and started doing that, and then it's kind of evolved into percs and all this other stuff. So, but open surgery is always a standby. We still do it occasionally, but probably less than 1–2% of patients with stones actually need an open operation. Thank goodness for them. The advantage of lithotripsy is, shockwave lithotripsy, it's an outpatient procedure. So, you know, you get it shocked, you go home, and you go back to work in a day, usually. Some not so. Okay, so treatment options. Spontaneous passage depends on the location. Is it proximal or distal? We talked about stones passing and how long have you had the symptoms. Usually, and this is very arbitrary, usually stones pass in 2 to 3 weeks, but not always. Some pass in hours. So some just don't pass. Then if it's in the upper, if it's a stone in the kidney, less than 2 centimeters, or it's in the upper ureter, then the simplest thing to do is shockwave it. Just break it up, let the fragments pass. If the stone is closer to over 1 centimeter in size, you all know what a centimeter is. Was it 2.5 on the average? 2.5 centimeters is an inch. So if it's over 1 centimeter, I generally put a stent in because you can get into some problems with passing fragments, and I'll show you actually that. You could do ureteroscopy, usually for the mid-ureter or lower ureter. That's good for using ureteroscopy. You could either pop the stone back up in the kidney and shock it, or you can just use laser on it, or you can just pull it out, or a combination. And if the stone's larger, we do percutaneous. Again, review of the different sites. So up here, 2 centimeters or later, percutaneous. Here, up to here is shockwave lithotripsy, or anywhere actually if you wanted to. Ureteroscopy down here up to about here. This is a stone. This is stone cancer. That's no contrast in there. That's just a stone, and that's from a paraplegic. Okay, so this is stone treatment would definitely be percutaneous. Way too big for doing shockwave. You'd be there forever. Some people try on some of these bigger stones. Look at this baby. Now, you're not going to mess with that. That's too big for anything except open the patient up, do it, and take the stone out. I mean, putting up a little ureteroscope and trying to break that with a laser would be a lot of work. Shockwave lithotripsy would leave a heck of a lot of stone. It would take forever to break that up and have everything pass. So best thing to do is just open that up. So there are some things we would just take right to surgery and open up. There's shockwave lithotripsy. You know how sound wave travels in water? You know, our government, our Navy has all these microphones under the sea. They can hear submarines and they hear whales mating from 1,000 miles away and all of this. So sound waves travel very well in water. And that's the same concept of lithotripsy. We generate a shock. You all have, you know what those antennas look like for your cable? I mean, if you have DirecTV, you got that big antenna with it, which is basically a dish. And then you have this little focal point away from the dish, and then you have the wires coming out there. So the waves coming in hit the dish, and it focuses to that spot, and then you get all of the information and the waves going down. You're the engineers here probably, so you know better than I. But the concept is you're focusing all of that to one point. Same thing with lithotripsy, but it works backwards. If your generator was where the little thing was in the front of the dish, that generates the shock. It sends it to the dish. The dish then focuses it away from where it's generated, several inches away, to the patient. And it focuses all that shock wave to one spot. And that's what you put in the crosshairs. You have an X-ray that correlates with where that focus point is, and that's how you shock the stones. Closer to the dish or where you generate them, it's less pressure, less energy, because it's spread out, but as it gets closer, it gets stronger and stronger. And we'll see some of the effects of that. Here's a concept of it. Here it is, just getting tighter and tighter to hit a kidney stone. Here's the generator focusing to a stone. Okay? Now, this is in Baptist. This is in the ER. I took this picture the other day. This is our mobile lithotripter. Here's your generator here. It's in here. This is water, and this is a little rubber thing that goes right against the patient. You know, you've heard the thing, we are 98% water. So we assume that we're all water, so it's going to be a continuation of a water medium from that generator to the stone. Now here's a picture of it in situ. There's a patient's legs. There's his belly button. And there it is. We flipped it around, and it's laying right over his kidney. And there is the x-ray to show us where, so we could use that as fluoroscopy to find out where it is. So that's how it's set up. Then we focus. You can't see this real well, but the stone is right here. There's a stent in, right here. Okay, and there's a rib somewhere, I think. Okay, so, and then you fire. Well, here's what happens after you do it. It goes pop, pop, about 60 to 120, depending on the patient and the stone, how many shocks per minute. We could give them 2,500 shocks. That's maximum in the kidney. Any more than that, and the kidney starts getting a higher risk of getting tenderized. You know, it'll get beat up, and you get hematomas and bleeding and that kind of stuff. So we minimize it to 2,500 shocks, and then the stone breaks. Now here's the force of that. This is what it does to the skin. That's where the thing was sealed around it, and then there's the shock wave. Causes a little bit of a bruise. Sometimes it'll excoriate the skin, and patients will kind of feel like they got kidney punched. They'll be a little sore. Okay, this is not. Patients are notified of this. They're aware. It's not a major issue. It goes away. It just looks. This one was particularly interesting, so I took a picture of it. Okay, so remember I said if you try to lithotrip too big of a stones, you get this kind of stuff. See this? That's called a Steinstrasse. Street of Stone or Stone Street. It's German. This is a Dornier lithotripter. The first lithotripter was in the 80s, brought to the United States. Dornier is a German company, and they did their studies over in Germany. And that's what it is, a street of stone. So you get all these stones fragments lined up. So that's if you take too much, if you bite off more than you can chew, you run that risk of a street of stone. And then this is another issue. So here's 2 stents in place. This patient obviously has very active stone disease, and they unfortunately, there's a stent curl there. They unfortunately tried to lithotrip, and they got too much stone in here. So you have to go in later down the road. This is keeping everything from obstructing. You go in with a ureteroscope and a laser and have to start mining all that stuff out with a laser and breaking it up and pulling out the pieces. It's a lot of work, and it's unfortunate in this case we don't get paid by the pound. Now we're going to talk about ureteroscopy, basically. We have to look in the bladder. That's a cystoscopy. We're not going to go through all this. We pass a guide wire. We dilate the urothelium to the kidney if we need to. We pass the ureteroscope up, and we do what we need to do. We can break stones up with a variety of different things. I'm not going to bore you with them, but the one we use mainly is the holmium YAG laser, the holmium laser. And that's very good. You'll see how that works. This we use, the lithoclast, is a combination of a jackhammer and an ultrasound. It's a little tube that vibrates at high frequency, and that high frequency breaks and dissolves, crushes the stone, and through the tube we have vacuum that sucks out the fragments. It's all in a water medium. So it has a jackhammer that breaks the big piece up into smaller pieces, then the ultrasonic lithotripter vibrates it to small pieces, and we suck it out. That's what we use percutaneously. It works very nicely. But it's rigid. It's not flexible. So that's a disadvantage, but it's really efficient. But mainly for this, for our interest, we basically use the, where am I? Got lost. We basically use the holmium laser. This is your ureteroscope. Briefly, there's a stent. There's your ureteroscope. It's long. So if this starts at the end of the penis, this will go up to your tonsils. Here's a stone that I basketed through this ureteroscope. Best shot I could get of it. Now here is a nice picture. This is in the ureter through my ureteroscope on another stone. This is a jack stone. This is a little piece that broke off of here. These are guide wires. This is a blood clot. There's a little fragment there. This is a calcium oxalate stone. It's a jack stone. Very hard, monohydrate. Okay, there's my laser fiber. Makes it red. You can't see it real well. It's just a camera thing. But this is a little red spot. So you start working on the stone and just breaking it up into tiny little pieces. And here's what this is a kind of part way through. You see I kind of got a big crater here already and a little chunk there. That chunk is probably a millimeter and a half in size. Okay. And then we break it up enough you could kind of pull out and pull them out, or a lot of these will pass on their own. You put a stent up and it'll pass. Okay. Now PCNL, primary therapy greater than 2 centimeters. We use that for big stones, difficult stones, staghorn calculi. Remember that one I showed you that looked like a kidney, filled with all stone? That's a staghorn calculus. Cystine stones tend to be softer. They don't lithotrip real well. And they just tend to be very difficult to treat. PCNL is very good for those. You go in and it'll take them out, or you break them up, take the pieces out. You also use it if you can't get through from below. For some reason, even a small stone, if it's blocked, you can go in from above and pull it from above as versus from below. Abnormal anatomy, some other things. If ESWL fails, you could always go back and do it percutaneously. A little more invasive, and you'll see why. But definitely good access to stones. You start off with access. You put a needle in through the back, and then you can wire it through the kidney, and you pass it down the ureter. Then you put a balloon in here, and you dilate it. These are the balloons we use. You can either serially dilate it with a dilator or use this balloon. It dilates the tract. You then get a sheath, and you slide it over the balloon, and you have access. Okay? Now, sometimes you have stones in different parts of the kidney, and you have to do it in different parts of the kidney. So we have to go upper pole, middle pole, lower pole. And these are going directly through the side of the kidney. Whoops, I got sidetracked here. Whoops, I'm going the wrong way. This thing's alive. We go through, and we can use that the lithoclast, the thing we talked about, that vibrates and breaks as a jackhammer. That's really good for big stones. It's godsend. But this is what it takes. But the good news is, when you're done, patient will have either no tubes in or a nephrostomy tube, which will be a tube coming out of one of those tracts, draining like a catheter, and then we'll take that out in a day or two once we know everything is okay. But it gets really big stones. In the old days, there used to be a big incision from here across to here, and they'd be in the hospital for a week or more, and they'd have about 6 weeks of recovery. Here, they're back to normal activities within a week. This is what it looks like. This is the sheath. This is the stones. We're going in here with the sheath. You put a scope in, and then you can do various things. Break it up, or if they're small enough, you pull them out. There's a 3-prong grasper. Here's kind of how, like a ultrasonic thing works. It vibrates, and we have a jackhammer to break this up. And then you get these pieces, and you slowly suck them out. You know, vibrate them and suck them out. It's just mining. Okay, so for conclusion, shockwave lithotripsy is the most common technique, and the reason it is because it's simple. It's an outpatient procedure. You come in, you get put to sleep, you get shocked, you wake up, you go home. So it's very nice for lifestyle. You don't miss a lot of work, and a lot better than doing open surgery. Percutaneous urology techniques are useful for large and difficult stones, abnormal anatomy, or failed lithotripsy, and sometimes we use it as a primary therapy for small stones if we have difficult access to them. Then that'll work also. We need to just evaluate the patient, the x-rays, and extenuating factors, and then decide and discuss with the patient what the best treatment is. But again, 80% of stones pass on their own. Ureteroscopy is the most definitive treatment for stones in the distal ureter. And surgery may occasionally be invaluable, like that one with that big rock in the pelvis. Then sometimes cases like that will be surgical, open surgery. Nowadays, though, we're doing it laparoscopically, so we don't even have to make a big incision. The Hippocratic Oath was definitely thinking of urologists. I will not cut even for stone, but leave such procedures for the practitioners of the craft. So Hippocrates was thinking of us. Okay, are there any questions? When we pull the stents out? When we pull the stents out, the kidney should not be bleeding at that time. They're very soft polyethylene, very soft. They don't cause a lot of damage. And the stents are in to keep the kidney open until the bleeding stops. And then so once we pull it out, it itself does not cause bleeding. And there's two ways to remove stents. One way is we don't leave a string on it, and then we have to go in with a scope into the bladder through the urethra and then pull the stent out with a grasper. We do that in the clinic. Or if the stone is only going to be in for several days to a week or so, I'll leave a string on it. Except for women, I don't trust women with strings. But men will leave a string on it, and we'll tape it to their phallus, and then they would just pull the string out, pull on the string, or tie it to a doorknob and slam, whatever you want to do, but we just pull it out. Just get it out. But with women, women just tend to don't handle strings well because we tape them to their thigh and they end up wiping themselves in the shower and they pull them out. And it's halfway out, and so they're wondering why they're leaking urine all the time. Well, and then we just tell them to pull it out after that. So we try to leave them in there. And cystoscopy is a lot easier on a woman. A woman's urethra is only, a couple inches long, while a man's is a little longer than that. So it's a less traumatic for a woman, and women are tougher than men. So anyway, any other questions? Yes? Oh, absolutely. Absolutely. The question was, are there ever kidney stones that are so bad that they lose their kidney? Absolutely. Chronic infected stones will kill off a kidney over years. Absolutely. Or, favorite case. Not favorite, it's a kind of tragic. I had a patient when I was practicing in California. He had a kidney stone. It was about 4 or 5 millimeters. It was in the mid-ureter. I said, okay, here's your stone. I want you to come back in a few weeks with an x-ray. If it hasn't passed or is not continuing to progress, we're going to have to do something. I don't like a stone to be obstructing for more than 4 to 6 weeks maximum. They did a study. They took dogs. They tied off a ureter. And then they untied the ureter at various amounts of time to find out how long can you have a total obstruction of a kidney without losing any kidney function once it recovers. The answer is 6 weeks. So a blocked kidney is not an emergency as long as it's not completely blocked for more than 6 weeks. So if you're totally blocked, I usually start moving at 4 weeks because of being conservative. But if it's partially blocked, it could probably go longer than that. But I usually, as a general rule, do not let anything go longer than 6 weeks without doing something about it. So anyway, this patient had his stone, mid-ureter. He never showed up again. He finally resurfaced when somebody noticed the stone on x-ray when he went to another doctor. He came back a year later. I did a study. He had a dead kidney. He was not having any symptoms. And the stone just blocked and killed off his kidney. But more likely is when you have infection, stones, it tends to deteriorate the renal tissue. And over time, chronic obstruction, the kidney will become literally an abscess. You just have to take it out. Take it out. That happens more times than I'd like to admit. Yes, ma'am. Uh-huh.
Is there, and it breaks up, is there a certain amount of time that it takes to pass all those pieces? I know it's not going to break up, it may break up in different size pieces, but is there a general time period when?
There's no general, the question was,
Could it be years?
Absolutely. The problem with the anatomy of a kidney is you have a dependent portion of the kidney. That's the lower pole. And if the fragments or the stone is in the lower pole, the chances of you getting that patient stone free drops dramatically. I usually have my patients go on a thing we call postural percussion. Spouses love this. You put the patient face down 45 degrees. The kidney you treat, you flip them up 45 degrees. The spouse beats on their ribs about 5 minutes twice a day. And what you're doing is you're shaking up that gravel, getting it up above the hump of the lower pole so that it could start going down the ureter. Otherwise, you'll just have a puddle of stone there, and it's just going to start being a nidus for more stone.
And the kidney stone, it starts forming at the top of the kidney? Is that how?
Not necessarily. Use wherever it could form it, just in the calyces, and that could be lower pole, middle, or upper pole, and then they could be anywhere. Generally speaking, though, we get a little more concerned about upper pole stones because they're more likely to pass. Now, there's a lot of people running around with small stones in their kidney, and we're not going to treat them. I mean, that'll put a warning flag, say, okay, you've got kidney stones. Let's see what we can do to prevent them from growing bigger or from forming more of them. And if they're 2, 3 millimeters, I'll leave them alone, and hopefully they'll pass on their own. You're not going to lithotrip them, usually, because they're first of all, they're very hard to see. Number two, it's overkill. It's overkill. But that is an issue. There's no set time how long it takes for a stone to pass. It depends on how much well it broke up, and that depends on what it's made of. And then you sometimes have to retreat it to break up the pieces even smaller to make them pass easier. Sometimes they get stuck in the ureter, and you have to go in and pull them out, or retreat a big fragment in the ureter. So sometimes you need additional treatments. The beauty of a ureteroscopy for the smaller stones in the ureter is you're just taking the stone out. It's gone. You don't have to deal with the fragments. Like the Steinstrass you saw. You know, those are the, well, you could minimize that, but a lot of times you'll get stones lining up the ureter along the stent. You have to wait for them to pass, so you pull the drain end thing out, and you have to, a lot of times they'll pass if they're small enough without doing anything, but a lot of times they won't. So that's one of the downsides of lithotripsy. Any other questions? Anything else about anything non-litho? Something other urologic? Burning questions you were afraid to ask? Okay, thank you.
Thank you, Dr. Deanna. We appreciate it.